A patient develops fever and back pain minutes after a transfusion. What's happening? Okay, let's dive right into this. Today we're tackling a massive, extremely high-yield topic for your USMLE Step 1 and Step 2 exams, blood transfusion reactions. We're going to break down exactly how to differentiate and manage these emergencies quickly and accurately.
Picture this classic ward scenario. You've got a patient who suddenly spikes a fever and complains of intense back pain literally minutes after a blood transfusion starts. What exactly is happening? Recognizing these clinical presentations in a split second, that's not just high yield for crushing your boards, it's absolutely critical for saving lives on the floor. These reactions range from mildly bothersome to rapidly fatal, and you need to know exactly what to do.
So here's our game plan for this explainer. We'll start with first steps in acute hemolysis, then move into febrile and septic reactions. After that, we'll break down TRALI, TACO, and allergic reactions, followed by delayed reactions and iron overload. We'll wrap the whole thing up with a high-yield summary table and test your knowledge with a few USMLE clinical vignettes. Let's get to it.
Section 1. First steps in acute hemolysis. Because when a patient starts crashing, you need to have reflexes of steel.
Okay, the absolute most crucial takeaway here. Step 1 is always, and I mean always, to stop the transfusion immediately. That is your first, undisputed, highest yield management step for any acute reaction. Boom, done. Next, you've got to maintain IV access, run some normal saline to keep the vein open, and stabilize their airway, breathing, and circulation. After that, get on the phone and notify the blood bank. They need to run a clerical check, because honestly, a lot of these severe reactions happen just because the wrong blood went to the wrong patient.
All right, our first major reaction is the acute hemolytic transfusion reaction, or AHTR. Listen, this is an absolute medical emergency. It's caused by ABO incompatibility. Imagine preformed antibodies in the recipient just completely destroying the donor red blood cells right there in the bloodstream. And this happens fast, usually within minutes to 24 hours. The classic USMLE buzzwords you're looking for: fever plus flank pain during a transfusion. You also might see pink or dark urine, which is hemoglobinuria. Now, besides stopping the transfusion, you need to hit them with aggressive IV fluid hydration. Normal saline is your best friend here because you have to maintain urine output to protect those kidneys from all that toxic free hemoglobin.
Moving on to Section 2, febrile and septic reactions. Fever is tricky because it's super nonspecific, right? So we have to learn how to distinguish between a benign cytokine release and a deadly bacterial infection.
So first up in this category, we have the febrile non-hemolytic transfusion reaction, FNHTR. This one is caused by cytokines leaking out from old donor white blood cells while they're just sitting in storage. It usually shows up within 1 to 6 hours with fever, chills, and flushing. But keep in mind this is a diagnosis of exclusion. You still have to stop the transfusion first to make sure it isn't the deadly AHTR we just talked about. Once you're sure it's just a febrile reaction, you can give acetaminophen for the symptoms. And here's a massive, highly testable fact. You can actually prevent this reaction entirely by using leuko-reduced blood products.
Now, on the much more dangerous side of the fever spectrum, we've got transfusion-associated sepsis. This happens when there's actual bacterial contamination of the blood product itself, and it's most common with platelets since they have to be stored at room temperature. The onset here is really rapid, usually within about 4 hours. And notice how wildly different this looks compared to a simple febrile reaction. These patients will hit a high fever, drop their blood pressure, and go straight into severe shock. After you stop the transfusion, your immediate next steps are to grab blood cultures from both the patient and the leftover blood bag, and then start broad-spectrum antibiotics right away.
All right, Section 3, TRALI, TACO, and allergic reactions. If you see respiratory distress on a board question, differentiating these causes is practically guaranteed to show up on Step 2.
Now, what's really interesting here is how perfectly we can contrast these two major pulmonary complications. On one side, we've got TRALI, transfusion-related acute lung injury. This is actually an immune mechanism. Donor antibodies activate the recipient's neutrophils inside the lungs, which causes non-cardiogenic pulmonary edema within about 6 hours. You're going to see hypotension, fever, but importantly, a normal BNP. Now contrast that with TACO, or transfusion-associated circulatory overload. This isn't immune at all, it's just a plumbing problem. It's cardiogenic edema caused by pumping in too much fluid too fast. So unlike TRALI, TACO presents with hypertension and S3 gallop, a really elevated BNP, and you actually treat it with diuretics. Definitely memorize this contrast.
Next up is the anaphylactic transfusion reaction. This is your classic severe type 1 hypersensitivity. The huge USMLE link to watch out for here is a patient with a known selective IgA deficiency who suddenly goes into immediate anaphylaxis. And I mean seconds to minutes after receiving any blood product containing plasma. They'll show up with shock, wheezing, angioedema. You literally have no time to wait. You must immediately stop the transfusion and hit them with intramuscular epinephrine.
But let's contrast that with a minor allergic transfusion reaction. This one is caused by preformed antibodies against donor plasma proteins, but it's way milder. The onset can be up to 4 hours, and the symptoms are usually just on the skin, like urticaria, hives, and pruritus. And what's really crucial to know for the wards is that this is one of the very few times you can actually restart the blood product. You just pause the transfusion, give them an antihistamine like diphenhydramine, and if the symptoms clear up and there's zero sign of systemic anaphylaxis, you can slowly start it back up.
Okay, let's step back and map all of this out. The timing of symptom onset is basically your biggest cheat code for multiple choice questions. If a reaction happens in literally seconds to minutes, you should immediately be thinking anaphylaxis or acute hemolysis. If it takes a few hours, you're probably looking at FNHTR, TRALI, TACO, or sepsis. If we're talking days, that points toward post-transfusion purpura. And if it's weeks, that strongly suggests a delayed hemolytic reaction. Seriously, lock this timeline in your brain.
Section 4. Delayed reactions and iron overload. We're shifting gears here to complications that pop up long after the patient has actually left the transfusion bay. This really tests your long-term follow-up knowledge.
So, the delayed hemolytic transfusion reaction, or DHTR. This is an anamnestic, meaning a memory, immune response to minor red blood cell antigens, things like Rh or KID. Because it takes a while for those antibody titers to actually ramp up, the onset is usually days to weeks later. And unlike that violent, rapid destruction we saw in acute hemolysis, this is an extravascular process. The red cells are just quietly cleared out in the spleen. So a lot of times it's totally asymptomatic, or maybe you just see mild jaundice and a weird, unexpected drop in hemoglobin. The good news? It's mostly self-limiting and you generally don't need any acute therapy for it.
And here are 3 other delayed complications you absolutely need to keep on your radar. First, post-transfusion purpura. This hits about 5 to 10 days later because of antiplatelet antibodies, causing a profound drop in platelets that you have to treat with IVIG. Then there's iron overload, basically a secondary hemochromatosis. This is incredibly high yield for patients who get chronic transfusions, like folks with sickle cell anemia or thalassemia. And finally, transfusion-associated graft versus host disease. It's incredibly rare, but it's essentially a fatal immune attack where donor lymphocytes attack the recipient's body. We prevent this by irradiating the blood for any immunocompromised patients.
All right, Section 5, the high-yield summary table. Go ahead and get your screenshot buttons ready, because this is the ultimate cheat sheet for your exams. Let's blitz through this together. AHTR happens in minutes. It's caused by ABO incompatibility. Your distinguishing feature, flank pain and hemoglobinuria. First step, stop the transfusion. Next, FNHTR happens in hours, caused by donor cytokines. Distinguishing feature is an isolated fever and chills. First step, stop the transfusion, give Tylenol. TRALI happens within 6 hours, caused by donor antibodies. Distinguishing feature here is non-cardiogenic pulmonary edema with hypotension. Stop that transfusion. And finally, TACO happens within 12 hours, caused by fluid overload. Distinguishing feature is cardiogenic edema with hypertension and a high BMP. First step for this one, respiratory support and diuretics. Organizing everything by timing and key features like this is exactly how you lock in that pattern recognition for the boards.
Section 6, USMLE Clinical Vignettes. Okay, it's time for some active recall. I'm putting you in the hot seat to see what actually stuck.
Here's vignette number 1. A patient receiving packed red blood cells suddenly develops a fever, chills, and severe flank pain. His urine in the Foley catheter appears dark red. Take a second. What's your diagnosis? Got it? Yep, it's an acute hemolytic transfusion reaction. Because of an ABO incompatibility, probably a clerical error somewhere down the line, preformed antibodies are literally ripping apart those donor red blood cells right inside the blood vessels. Just remember that high-yield USMLE tip. Fever plus flank pain plus hemoglobinuria during a transfusion, that equals AHTR, and you have got to stop that transfusion immediately. Okay, let's try vignette 2. 2 hours into a transfusion, an elderly patient develops severe shortness of breath. On exam, you note a blood pressure of 170/95, bilateral crackles in the lungs, and an S3 gallop. The BNP is also elevated. So what are we looking at here?
This is a classic textbook presentation of TACO, or Transfusion-associated circulatory overload. The massive clues that should steer you completely away from TRALI here are the patient's older age, that high blood pressure, the S3 gallop, and the elevated BMP. This is cardiogenic pulmonary edema. And remember, unlike TRALI, TACO responds beautifully to diuresis because at the end of the day, it's a plumbing problem. It's an issue of volume overload, not an immune reaction.
So we've covered the whole spectrum today, right? Everything from rapid immune destruction to subtle volume overloads. But honestly, it kind of leaves you thinking, with all of these wildly complex immune interactions and fluid dynamics happening, what other hidden, long-term risks might a single unit of blood hold for our most vulnerable patients? I mean, every blood bag is essentially a liquid organ transplant, with all the profound complexities that entails. Keep asking those questions, keep crushing your studying, and we'll see you in the next explainer.